Can anybody hear me?
We can hear you.
Okay. Thank you.
I will be muting everybody just to let you know. If you have questions, you can raise your hand. We will be stopping frequently through the webinar to ask if you have any questions and provide responses. Thank you.
For folks who are just joining us, please go ahead and put your name and county in the chat. And if you are an agency or a prevention provider, please put in your agency name as well. We're going to start in just a few moments. The admit from the lobby is taking a little longer than we were expecting. But for those of you who are joining us or just joined us, please make sure you put your name and county into the chat. And if you are a prevention provider, please make sure you also include your
And then put
All right, for those of you just joining, sorry, we're getting some feedback. For those of you who are just joining us, please make sure you put your name in the chat with your county name as well. And if you are a prevention provider, please include your agency name. And I think we have made it through all 109 of us who are now on the call. So we're going to go ahead and get started. So Lorraine, if you'll take over admit duties for those few stragglers, I'll go ahead and begin. Okay, so again, as a reminder, please make sure you put your name and county into the chat. And if you are a provider, please include your agency name. We'd like to say hello and welcome to the Data Quality Standards or DQS webinar. We're glad you could join us today. My name is Angelina Azevedo, and I'm the manager over the Prevention Outcomes and Reporting Unit. Joining me today will be Lorraine Frias, who will be sharing content about the DQS. And we have Jeanette Triguerio from our team who will be monitoring the chat. So you'll have an option to either raise your hand and ask questions or to place your questions into the chat. So today we will be providing a brief overview. Excuse me. Today we're going to be providing a brief overview of the Substance Use Disorder Primary Prevention Data Quality Standards and Definitions document. Quite a mouthful, so DQS for short. That is part of the Substance Use Block Grant contract. Changes to the data quality standards took effect last July 1 of 23. And it is important to note that the data quality standards apply regardless of the data collection platform DHCS utilizes to collect SUD primary prevention data. A copy of this document that you can share with your county teams and your providers was included with the invite to today's webinar and can also be found for those of you who have ECHO access in the briefcase, in the ECHO briefcase. So you've got several sources already at your disposal, but if you are having trouble locating a copy of the document later on, make sure you're reaching out to your DHCS prevention analyst, and we'll be happy to provide that for you. This revised document integrates the two former contractual documents entitled Data Quality Standards for Prevention Services and Center for Substance Abuse Prevention Strategies and Activities Definitions and Matrix. So for those of you who have been around longer than a year, you may remember that those were two separate documents. This particular document, as we pointed out last year, does combine those two so that you have it all in one handy place. Let's go ahead and begin by taking a look at Chapter 1, Purpose. The purpose of this document is to identify and define the data standards for counties and subcontractors that receive substance use and mental health services block grant, or the sub-G, for substance use disorder, primary prevention, set aside funds. The outcome is for the Department of Healthcare Services to report complete and accurate data to the federal funding agency, SAMHSA. Also stands for Substance Abuse and Mental Health Services Administration. DHCS utilizes prevention data for SAMHSA's annual sub-G report and application, as well as other national, state, and local data requirements. Primary prevention focuses on strategies to prevent all levels of substance use and includes a range of services for individuals, families, communities, and the society at large. The Code of Federal Regulations, or CFR, defines primary prevention as strategies directed at individuals not identified to be in need of treatment. And that is very key, that idea that they cannot be in treatment when you are utilizing sub-G funds. Prevention services are appropriate for individuals who have not received an SUD diagnosis because of an addiction to a substance. The federal funding California receives and distributes to the counties through the sub-G grant is specifically earmarked or primary prevention services, regardless of the system of care that your county department oversees those prevention services at the county level. To meet the DHCS data quality standards, it is important to understand that the chapters we will briefly review today will be Chapter 2 for data quality standards, Chapter 3 for the primary prevention strategies, Chapter 4 for the Institute of Medicine or IOM categories, as well as the demographics. The chart on page 3 outlines the tables for the specific data requested by SAMHSA in order to support the state's application for continued sub-G funding. Are there any questions about this first chapter before we move on to Chapter 2? Feel free to raise your hand or put your question into the chat. Okay, seeing none, we'll go ahead and take a look now at Chapter 2, the actual data quality standards. To ensure data integrity, DHCS commits to data that is valid, timely, accurate, unique, thorough, and auditable. So here's a quick review of each of those 6 categories. So for prevention data to be valid, prevention does not include the following services: SUD treatment, recovery, relapse prevention, early intervention, secondary or tertiary prevention services, mental health services, primary care services, or tobacco cessation services. They may not be used for enforcement of alcohol, tobacco, or drug laws. However, they may be used to provide technical assistance and education to maximize enforcement. Under prevention data that is timely, the data entry adheres to deadlines. Contractually, for our purposes, that is the 10th of the following month. So, for example, June's data would be due by July 10th. For accurate data, prevention services classification must be correct, primary prevention strategy, IOM category, and evidence-based status. This document provides guidance on definition and demographics. For our 4th element, data is unique. Users will enter non-duplicated service activity times and demographics under the correct program. The service duration accounts for the time of the actual service, not the cumulative hours staff attend the service. For our 5th, prevention data is thorough. The data follows the required format and structure. You'll set up programs with accurate program names and descriptions. And this document again provides guidance on format and structure. For our last element, that it is auditable, the data is accurate for review and edits. Counties and subcontractors should have a trackable identification number referred to as the master profile file, MPF identification number. Internal policy and procedural documents for the county and subcontractors should be maintained by DHCS requests and audits. And in order to receive that master profile file number, the MPF, you would contact your prevention analyst to get you started with that. And there's a form that is sent to take care of that. So, are there any questions about this information so far? Please either put your question in the chat or raise your hand. Nothing. Okay, great. Well, I'm going to stop there and pass this.
I have a question.
Oh, somebody has a question.
Yeah, do you know how to, just making sure you know how to raise your hand on the actual computer, like up on top, you should see a little hand that says raise. So if you could click that, then you'll be pushed to the front of on our screen, because there's over 100 people on here right now, but I did see you, Ida. So Ida was raising her hand.
Okay,
I did try
excellent.
it, but it wasn't. So I'm like, just to clarify, that number that you're discussing is something that we should ask ahead of time in case we need to contact you guys later?
For the MPF number, is that the one you're asking about?
Yes.
Okay, so with that number, that's the number that we use in Echo to track that your provider is a Medi-Cal provider and can receive funds. So, yeah. So all of your providers right now should have those. If you have a new provider coming in, that is when you would reach out to us and say, hey, I'm going to need this. And then we get you connected to the
Okay, thank you.
folks at the provider master file.
Yeah, that our organization Ida is through the county. So providers do not need to contact the state. The county and the state will be handling all of that.
I
So-
didn't catch where it says for Medi-Cal recipients or providers. It's like we are not, so that doesn't pertain to us.
The MPF has nothing to do with if you're a Medi-Cal provider. Everybody who is a provider receiving primary prevention funds will receive an MPF number.
Okay,
I'm sorry if I confused you there.
all right, thank you.
And I think, do we have anybody else with their hand raised or with a question?
My hand was up actually. So
Okay.
my name's Jeanette and I'm with DHCS. I'm a prevention analyst. And I just wanted to give a little bit more information about the MPF, the master provider file number. That is a number that helps DHCS track providers that are contracted with counties. So if you're contracting with a provider to provide primary prevention services, that provider must have a master provider file ID number. Okay, so if you're hiring a new provider that has never done prevention in the state, then you would need to reach out to your prevention analyst and request a new provider ID. Okay, most of the providers that we see in the state of California already have one, so it's not usually an issue. But if you have a new provider that you're contracting with, you need to let the state know you're contracted with that provider. And that's how you do it. Okay. Hopefully that didn't confuse everybody.
I would just like to clarify, because that was, this was recently changed one of our provider information on that, and the analyst at the state gave me, sent back the request for the change because I didn't have the NPI number, which is different and from what you're talking about, and
Yes.
and so I just clarified that it was a prevention provider and we do not do the NPI numbers. That is for the treatment side. Is that correct? Is that he followed through with it? So I'm not clear about all that.
Right. The only number that prevention providers have is the MPF number.
Okay, thank you.
Okay.
Okay. Any other questions? Okay. And Katrina, I'm going to ask if you could mute your, there you go. Yourself. There you go. Thank you. All right. So I'm going to pass this over to Lorraine, who's going to take you through chapters 3 and 4.
Okay, I'm Lorraine. Hi, everybody. I've been with the state since 2012 as an analyst, but I've been doing prevention in the field for over 25 years. So if you have, I can fairly know and how to respond to program questions, and that's why I'm doing this chapter, because in prevention we are federally regulated, and the federal at the federal level with SAMHSA, they do I guess we could say categorize all of the services that prevention does with 6 strategies. And so when you enter your data, you'll see that when we set up programs, and again, program setup might be done with just us in the county, but some counties do have their providers create programs, and you'll have to select a strategy for each of your programs. And that's what I'm going to go over with you right now is the primary prevention strategies. They used to be called the CSAP 6. So if you hear someone at a training say, oh, the CSAP 6, they're referring to the primary prevention strategies. And CSAP just stands for Center of Substance Abuse Prevention. So the first strategy, and none of these are more important than the other, I want to make that clear. We do so many things in prevention. You know, we don't only do direct service one-on-one. We do other things. So under information dissemination, you'll see these, other types of things because outreach is huge in prevention. So information dissemination provides awareness and knowledge of the nature and extent of alcohol, tobacco, and drug use, abuse, or addiction, and the effects it has on individuals, families, and communities. And so here, we always want to focus that we're disseminating information, and it's usually a one-way communication from the source, which is whoever is providing the information to the people you're serving. For example, like a health fair, right? You might be tabling and you're passing out pamphlets, and that's one way. They might ask a couple of questions, but it's not an intense service. Or what we might call in the field a direct service is when you're one-on-one with a participant. We try to stay away from the term client because client is very treatment and mental health focused, whereas prevention will usually refer to the people we serve as participants or members. And now we're starting to see the term customer is used a lot in both, like across systems. So we're starting to see that a lot in narrative. So we're going to just list a couple of examples that we can put services under. So anytime a community, school, or outreach event is happening, health fairs, health promotions, school rallies, assemblies, town halls, those would come under community school outreach events. Internet website development and maintenance, of course, now we're seeing tons of information being disseminated online through websites, social media platforms. So we definitely want to capture all of those hours that staff are putting into developing and maintaining this. And then multimedia is any visual media that you do, like PowerPoint presentations. Maybe you're using photography or any PSAs or public service announcements, campaigns, blogs, things like that. You can put any time you spend working on those under multimedia. Presentations usually are one way. It's like when you go in and say you're doing the consequences of cannabis use on a youth brain or something like that. It's a 60-minute presentation that would come under here, under information dissemination. And then of course, printed materials. So the time you take creating or writing pamphlets, brochures, things that are going to be disseminated publicly, you want to put that time in here in printed materials. The time you take researching, doing it, and then disseminating it. All of that time can be placed in information dissemination. And then we have resource and information services. And this is usually like when you have a hub or a clearinghouse or a resource center. Sometimes it's a walk-in. It could also be over the phone, but a resource line or a resource center where people have access to ask questions or find out where other resources in the community might be. That time would be under resource and information services. Questions on information dissemination. Moving on. Education. Now, in education, now we're talking about direct services. Education is a two-way communication and distinguished from the information dissemination strategy by the fact that there is interaction. So it is a direct service between the educator, the facilitator, and the participants based on activities. So this is like any time we're doing curriculum in the classroom or in another community-based environment where there is communication occurring and some type of learning. And also, hopefully, you're evaluating and you're taking time to do pre and post evaluation. So community school educational services. This is curriculum, seminars, interactive meetings, workshops. So like programs like Too Good for Drugs would live here. Botman's life skills. This is actually curriculum, okay? Whether you develop the curriculum uniquely or it's an already established curriculum. Mentoring also falls under education, and mentoring is defined as a formal partnership between a mentor and mentee. It could also include group mentoring, but when I used to hold mentoring, I used to do group mentoring, so it would be me and about 4 or 5 other young people. That would have counted as mentoring, so it's just not one-on-one. And then parenting family management services also falls under education. That's when you're providing services to parents, adults, regarding their roles as caregivers. Even if it's a mandated, like you might be working with a young person and also provide parenting classes that's mandated, that would also count. So any parent and family management. Strengthening families is a popular one that we use in prevention. So everybody's programs are very different. And then peer leader helper programs. These are services where you would use like high school students to work with junior high kids or high school students to work with elementary level students, but it is when peers are trained by the provider, by the adults or mentors, to provide some type of service. We see this a lot in tutoring programs where you'll have a junior high school student work with it, maybe an elementary level student. Questions around education? Either.
We have a program that's titled Hidden in Plain Sight. Under SAMHSA, it's an educational or evidence-based program, actually, not educational. And I was having difficulty trying to place it. We're currently putting it under info dissemination presentations, but it kind of also falls into the community schools aspect. Have you heard of it, or are others using it in a different place?
I have not heard of that program, but if you want to get the description of the program, and you could even put it in the chat right now or send it to your analyst. What county are you, if I can ask?
Tulare County.
Larry?
And we discussed it, and he basically explained that it could go either one, whichever I felt more comfortable. Because it's not curriculum based, I just went ahead and put it under presentations. But I was just curious how to distinguish one from the other, because again, under SAMHSA, it was evidence-based,
Yeah,
but
so
it's not curriculum.
yeah, if it's under SAMHSA as evidence-based, I mean, we would clearly want to capture it as such. But what I would ask my counties, if we were deciphering between this, is how long are the sessions that you're with the participants? And that would be the first. Second, I would ask what how long, and then will you see them again? If you will see them again, that means it's going to be like, even if it's an hour, but if you will see that same group again, then it's it's a program, right? It's recurring, you're forming a relationship. So that would tell me that it would go under education. Right off the bat, if you're gonna see the same group more than once, would put it under education. The third thing that I would ask is if you're evaluating.
Okay,
Is there a
so,
pre and post?
so the only part is the number 2. We won't be seeing them again. It is a 2-hour, actually it's 3 hours interaction. It is an interactive presentation where they're actually going through a simulation, and then there's a discussion about it, and then they have another opportunity to go through the simulation again.
Okay, because it's 3 hours long and there is this whole process, I would tell you to put it under education.
Under education, but even though that we won't see them again.
Correct, because it's 3 hours long and you're doing simulation and you're probably doing a like focus group type pre and post possibly. I would put it
Yes.
under education and make sure that if you are going to put it under education, that you are collecting demographics. Because
Okay.
once you put it under education, you'll be required to report demographics.
And this is adult oriented, so this would be under parenting, family management.
If this is for adults, yes, you would put it under, well, it depends. If the goal of the program is to like do a parenting class for them on how to parent, it would go under parenting. But if you're teaching adults how like about drugs and things like that, then it would go under community school education.
Okay. That sounds good. That's where okay. That works. All right. Thank you.
You're welcome. Can you please mute yourself? Thank you. Is there any other questions? Okay. That was a great little role model either that we had, because it shows exactly the thinking behind how to choose the correct strategy. And often information dissemination and education is probably one of the most gray because of the presentations under ID. Information dissemination. I'm moving on to alternatives. So alternatives is the participation of a population in activities that exclude substances. It assumes that if we construct and facilitate and offer healthy activities, that young people we will deter young people from participating in activities where substances are available. And so you'll see some of the examples would be like drug-free dances, youth adult leadership activities, drop-in centers, community service activities. And so here, community service activities, we literally mean like community service. When you get a group together, whether it's a combination of adults and young people or just young people, but working together to beautify community, clean up the community. You know, if you're in a high drug trafficking area, and you go into those areas and do cleanup, that, you know, then you're kind of right, putting things together there. Social recreational activities is just that, where young people have a safe space and a good time without using substances. This is when you're taking your kids out, right? And I just want to say with this social recreational activities, when we're working with young people in that are underrepresented or suffer from poverty, this is huge for our children, right? This is a huge thing because they don't normally get to do these things. And I would just take my kids out to the beach because they would never been to the beach before. And it didn't cost a lot, and we would make our lunches and go. So I just want to say, like, depending on your populations, this can really be something very beneficial for some of our young people. I had a couple of kids that just wanted to go and have me take them through the car wash. And that's what we would do, go through the car wash and go get ice cream. Simple things. Youth adult leadership activities are services where youth and adults work collaboratively toward a common goal. Usually with youth adult leadership activities, we want the youth voice to be heard and highlighted. It should be developed and created by youth for youth, with adults being the ally. So please understand that difference. Friday Night Live, for those of you that do FNL, that is like one of our biggest youth adult leadership or alternative activities for the state. Questions on alternatives? I'm going to move on. Problem identification and referral. So this strategy aims at identifying those who have indulged in inappropriate use of substances, and maybe it's their first time. But what we do with problem ID and referral is to assess if the behavior can be reversed through education. Remember, we're not clinical, we are educators, so we're always going to try to reverse through education. It should be noted that this strategy does not include an activity designed to determine if a person is in need of treatment. So I do want to be very clear about this, that prevention assessment is prevention assessment. There is a such thing as assessing for prevention needs, because we have, which I'll show you later, there's 3 areas of prevention based on need. And so you can refer a young person to get a treatment assessment, but you will not fund a treatment assessment under prevention. So one example is brief intervention, not to be confused with early intervention. Brief intervention is a risk reduction model. It does require trained health professionals to provide these services. And again, these are personalized conversations. We sometimes call them motivational interviewing, but it's when we want to identify and provide some brief sessions that maybe we can reverse the use. And we're not talking about, it might be just first time use, or they got caught with substances or paraphernalia and they were told, okay, we're going to try this brief intervention. Brief intervention may conclude that a referral for selective or indicated prevention would be necessary. Brief intervention programs vary, but could include the following components. Again, motivational interviewing, strength development, parent guardian, family involvement, screening, cognitive behavioral therapy techniques, and stages of change theory. EAP employee assistance programs are voluntary work-based programs that offer free confidential evaluation, short-term counseling, referrals, follow-up services to employees who have personal or work-related problems that may involve substance use or misuse. Prevention screening and referral is, again, when you're screening for prevention, it aims to determine the most suitable primary prevention program that will address an individual's level of need. The outcome of prevention screening will either place an individual in an internal, selective, or indicated prevention program, or refer them out to another program that provides selective or indicated prevention. And then there's some examples of some screening tools that we've seen counties and providers use. And then the student assistant programs, SAPs, is a school-based framework. Some people will use an SAP to do screenings. and see like what types of services the young person or even their family might need. Questions around problem identification and referral. Community-based process is another primary prevention strategies. These services under here, they enhance like providers and agencies and collaborative partners to do the work. So here we're organizing, we're planning, we're enhancing efficiencies and effectiveness of our services, collaborations, coalition building, networking, some activities under, again, remember I had said earlier, the same with information dissemination is community-based process. We're not directly with our members or participants or customers. We are working with each other to provide best services. And a lot of our work is organizational work where we're developing communities. So a lot of that would fall under here. So one is accessing services and funding. This could be when you're meeting with your counties, coordinating, monitoring funds, ensuring quality assurance, protocols, researching and applying for other funding sources. All of that time you spend doing this goes here. Any time you spend in coalitions, whether you're facilitating it or participating in it, you can put under here coalition work group activities, evaluation services. This is the systematic collection and analysis of information about your programs. Are they working? Are they effective? Do you need to change to maybe you need to change some program, but that's evaluation services would fall under there. And it could be either staff doing the evaluation or you are some counties will subcontract an evaluator to come in and do this work. Multi-agency coordination collaboration, that's internal or external meetings with your stakeholders, your staff, but your meetings can go under community-based process. And then primary prevention strategic plan development is any time you're taking to do strategic planning. And that means that you're using like a strategic prevention framework. We have it noted here and referenced to do your planning, your local planning. This can be happening at all levels. It could be happening at community, grassroots. It could happen in your agency. It could happen at county level. So it's available for you to put any time you spend developing strategic planning here. And then training and technical assistance is anytime you are receiving training or technical assistance, like right now, the hour you're spending or hour and a half you're spending with us today, this time would go under TTA. Questions around community-based process?
Lorraine, we had a question come in about the information disseminate or the problem identification and referral strategy.
Okay.
The question is for problem identification, does the screening tool have to be a formal screening tool or can we create our own screening tools?
The one thing I love about prevention is that we always are considerate of the environment and the people that we're serving. So yes, you can create your own screening tools. You know your communities, you know the people you serve, and sometimes formal, screening, those have their purpose, but we also have I don't want to say power, but we have the go ahead to do what we need to do what works. That's what one of my professors used to say, DWW, do what works. So yes, you can create your own. Any other questions? And so I'm gonna just take us off a little bit. So when you're creating your own stuff, that time would go under information dissemination. But when you're actually implementing it with your participants and members, that's when it's going to come under problem ID and referral. Because creating a tool to screen, could take some time. And then you have to get it approved and all that. So all of that time would go under ID, under like printed materials, like to create printed material. I'm moving on to environmental. And usually I'll tell counties off the bat, if you don't know what environmental is, you're probably not doing it. If you haven't been trained in environmental, you're probably not doing it. And when we're talking about environmental, we are not talking about like doing environmental work or cleaning up the streets or growing trees. That's not what we're talking about here. It's a lot of things under environmental, and it's very specific. So under this strategy, what we're doing is we're establishing or changing written and unwritten community standards, codes, and attitudes by influencing the prevalence of the substance abuse in a general population. This strategy can be divided into two. One would be legal and regulatory initiatives, and then those related to service and action-oriented initiatives. And so I'm going to go over some of the examples that we have. And I am going to read this verbatim because this narrative was created by counties with their input. And so I am going to word for word read this. And then if you have questions about it, I'll pause. Environmental prevention utilizes a public health model, a comprehensive multi-strategy epidemiological model that attempts to prevent or reduce a particular illness or social problem in a population by identifying risk factors. By considering human factors, sources of harm, the social environment, the environmental strategy promotes systems change to address population-based challenges that impact access and availability of illicit and licit substances. Policy can be in the form of an ordinance, a document site, event-based limitation, an agreement, a restriction, or a law. Policy efforts may include community mobilization, collaboration with government officials, policy-specific training, policy-related media efforts such as media advocacy, social marketing, and social norms campaigns. Environmental strategies categories include enforcement, public use, access and availability, retailer responsibility, access and availability, and social drivers of health. The term product includes substance-related merchandise, and/or paraphernalia. And so there's paraphernalia is the equipment and or material of any kind that is used, intended for use, or designed to aid in substance propagating, cultivating, growing, harvesting, manufacturing, it's a whole lot of stuff. So we're talking about policy here, we're talking about mobilization, and we're talking about communities also being a powerful instrument in this work, okay? So enforcement, under enforcement, we have driver-focused laws, and that's like alcohol units, impounding laws of vehicles, random blood concentration, testing for drivers, open container laws. And please remember that enforcement, we're not able to fund these, but we can work with law enforcement to educate and mobilize communities. And then you have your sobriety checkpoints. Again, we can't pay officers to do them, but what we have seen is agencies, staff be at a checkpoint passing out information. Social host social host policies are make it unlawful for persons to allow minors to obtain, possess, or consume substances at parties held at private residences or premises. So a social host ordinance is when adults are allowing young people to drink in their homes or in a location where adults are present. Surveillance, enforcement, observation of persons under locations to prevent illegal consumption, sale, or manufacturing of product. Again, we don't pay enforcement to do this, but we are like the gatekeepers of youth programs and youth participation. So like shoulder taps and minor decoys, our agencies might have our kids do the shoulder taps or be the decoy to go into a retailer and see if they can purchase without asking for ID. Underage focus laws, policies impacting current laws or sanctioning the enforcement of existing laws that impact minors. Examples: driving without a license, curfew, minor consent, driving privileges. Again, minor in possession, and a trace program. Not sure if many of you have heard of that. But trace program is basically like if you have a person in the hospital or even death, and it traces back to where they received the substance, and that's what that program does. Public use, access, and availability. All of this is basically around policies to deter like distribution, growing, the growth of product. So you can have PCNs, public convenience and necessity determination, DAOs, deemed approved ordinances. And again, all of this is working with like your city government to place some type of utilization and zoning law or ordinance, something like that. Public space use and sales policies that control product availability in places and events open to the public. So here we could be talking about, I think what was Santa Clara just had a cannabis festival, reggae festival, things like that, where you just, want to maybe go in and say, okay, could we not have this, or make agreements with people putting on these events. So purchase time limitations, product free sit stand areas, especially when they're allowing young people to attend. Then you might say, look, could we put a 21 and over on this event? That would make the community more safe and our kids more safe, things like that. School workplace policies that eliminate settings or circumstances for employees and or students to use or distribute product. And then substance disposal, a lot of us are doing this work. So policies that coordinate safe and proper storage and disposal of product. These are our take back days, lockbox programs, drop box programs, destruction bag programs. And then that we have this whole big thing with the child safety and locks in our houses. And now we're starting to see like a lot of programs, locks for substances and guns. Retail responsibility, access, and availability. So now this is all retail work. So product distribution and delivery, policies that focus on the regulation of retailer distribution. Now we're starting to see home delivery restrictions with cannabis, CAG restrictions over prescribing efforts. All of that would come under here. And so like working with pharmacists to create prescriber policies, things like that. All of that work would go here. Retailer compliance and recognition. This is outlet policies to develop or amend practices and procedures to comply with local state compliance. We have the responsible beverage service training that would go under here, lead, any training and intervention tips, medical marijuana regulation and safety acts. So this is just I would say Santa Cruz is a pretty intense county around environmental work around marijuana, cannabis. retailer laws and regulations, so state level policy development, adoption, and or enforcement to deter product use or availability, retailer permits, minimum age purchase, legal hours of sale. And then finally, we have social drivers of health, policies that impact the conditions and the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risks. And we've divided them in 5 domains: economic stability, education, healthcare, neighborhood and built environment, and social and community context. Any questions around environmental? I'm going to say a little bit of something on social drivers of health. I don't want you guys thinking that because you're have a program in South Central that's automatically SDLH. It's not. So when we're working around social drivers of health, we definitely have already assessed the communities that we're going to work in, which underrepresented communities we're going to be in, and then what they need to build. It's not us telling them what they need. It's us maybe helping them build a coalition of community members, and that takes a long time to empower. Or I don't even want to say we're empowering, because who are we? But when we're starting to create this space to build coalitions, and then the coalitions and the people themselves are starting to build and empower within themselves, with us being their ally, and they're telling us what their needs are. That's what we're talking about here. It's important that the communities are driving their health and what their needs are. And when that starts happening, then we could start looking at it as environmental work. So if a community comes together and they say, this is happening in our community, this and this and this is what we need, and then we become their ally, now we're talking about social drivers of health. Is that clear? Because it's not us telling them what their needs are, or us doing an assessment and saying, here's what we're going to do and you're going to do the work. It's them empowering themselves, and we might aid in that, but that they are knowing exactly what is affecting them, and having their voice be heard.
Lorraine, before we go on, we've got a question in the chat, and I see Ida's hand is up. Ida, why don't you go first? Yeah.
Thank you. The public use, access, and availability. Under substance disposal, that in our area, we work with our local police departments, sheriff's departments during the DEA drug take back day. So would that us helping them out during those events, it would fall under here instead of like a health fair situation?
Yes.
Okay. All right. Thank you.
Okay, and then in the chat, it says environmental. If the youth out of FNL are working on ordinances, where should we build the time, FNL or environmental?
If, remember, the service that you're providing is FNL. So it's going to be under alternatives. What the youth decide to do, because they could go any route, right? They could go this way, that way. That's them doing what they want to do. Our interaction with them is supporting them create their whatever assessment, whatever that looks like. It's the mentorship from us to them. So all of that will fall under alternatives Friday Night Live. Whether they're doing an environmental strategy or an educational strategy, that's their program.
Okay, and we had another item come in on alternatives. So With alternative activities, is it just doing an activity that does not include substances? Or is another aspect needed, such as substance prevention education during these activities? Knowing that environmental strategy has been a bit fine-tuned, if social norms, unwritten community standards are being worked on, how would a document
Let me
be
do the
added?
first question.
Yeah, I think it's a separate question.
Yeah.
It's all the same person, but it's a different thing. So,
First
so let's do the
question
alternatives one first.
is, does there have to be an educational component for alternatives? That's no. The second question, go for it, because that was gonna
Okay.
sound hard to answer.
Yes, yes. So the environmental strategies have been a bit fine-tuned. If social norms, which in parentheses, unwritten community standard, are being worked on, how would a document be added showing that a particular social norm is being worked on? I'm not sure what document would be added, but maybe Joyce would like to unmute and ask her question more specifically.
So if you're following the strategic prevention framework, which is the 5 steps: assessment, capacity building, planning, implementation, and evaluation, whatever document that comes out of that, that's individual, right? Like, you couldn't create a strategic plan just for one social norm. You could. I don't know what you would call it. That would be up to you and your strategic collaborative, whatever that board is looking like. If it's a community entity, and that's how I'm saying with like social drivers of health, or when community is involved, which in SPF, community should be involved in all levels, starting from assessment all the way to evaluation. So whatever that's going to look like, sometimes when communities are the main organizers, they might need help with just that. We're going to do this work, but can you prepare the documentation for it? And what are we going to call it? I mean, the state's not going to tell you what your planning should look like, or how do you get from A to E. There's already a framework telling you how to get from point A to B. And I don't know if that's helping at all. But what in California, at least what I love about us, is that we do provide local level sovereignty. You know, we're not telling you you need to do this, this, and this. Here's the frameworks, here's the categories, and you're the experts. Do what it is you need to do efficiently. And that's in the SPF, if you follow SPF.
This is Joyce. My my original understanding of environmental was pretty wide open, and then, like I said, it had gotten fine tuned. So my current understanding is, unless we have some sort of document to attach to, like ECHO, for example, to be able to sort of get credit, for lack of a better term, for environmental strategies, we had to have some document, some sort of ordinance, some sort of law, some sort of regulation that we were working on, which, you know, if you're working on social norms, that's going to be difficult to document, I guess, for lack of a better term. There is no document that says this is the social norm.
Joyce, are you a provider or are you a county?
County.
County.
Okay. Okay. I just thought maybe that was the
county level. So I'm gonna I do want to make a point that if my team, or Angie, could you write this down, because I think this is an important concept that we really need to work on a little bit further. But there was never anything coming from us stating that you had to provide a document to work on, you know, a certain environmental project. With social norms, we did say that it was going to need to be tied to policy, because campaigns falls under information dissemination also. So if it's just like a campaign And this is going to be a horrible one, right? The Say No to Drugs campaign. Who does that? But it's going to go under ID. But now if you say I'm doing this campaign on social norms, and because we're moving towards a policy to do this or this, then we could start putting it into environmental. But if it's just to distribute a one-way information in a regular campaign with no policy backing to it, it will go under information dissemination.
Okay, thank you.
Lorraine, I have a question about that, if I can ask. This is Jeanette. So the policy, does it have to be working toward policy, and once the policy is established, after that, all of the information about that policy and making that policy known, that's information dissemination at that point? It's no longer environmental? Is that true?
No, I would say it's okay to keep it all under environmental. If it's environmental work, it should stay with environmental.
Okay, thank you.
Even the organizing around it and getting people mobilized around it. And again, that's the difference. Again, when we're talking about environmental, we have community involvement. Where we're talking about campaigns that's just coming from agency, then there's no community involvement and no mobilization around it. Where is the community saying they need this? It's not. It's agencies saying, oh, we're going to do this campaign. So you're going to put it under information dissemination. And now, Joyce, as we're getting more educated around social drivers of health, we began to start building these implications and criteria.
This makes more sense. Thank you.
You're very welcome.
Lorraine, Maria has her hand up also. So Maria, why don't you unmute yourself? Okay, go ahead.
So I just wanted to confirm that I understood. So if we're working or collaborating with local public health departments to educate, for example, local retailers on policy that has been passed in local jurisdictions, that would fall under environmental.
If you're just educating people, and if you're just educating your partners, that's going to go under community-based process. If you're just educating, like, hey, this is what we have, to other agencies, that'll go under community-based process as a collaborative meeting or a collaborative or a coalition, wherever that's happening at.
But if we're educating retailers that are impacted by policy work that has passed in local jurisdictions, it would fall under environmental, correct?
Yeah, there's a retailer education over here. Like you could put it, it's going to fall under retailer responsibility, and you could put it under retailer compliance and recognition.
Got it. Thank you.
Mm-hmm. Yeah, because I don't know, are you doing RBST where you're doing the retailer beverage service trainings and things like that? Like if you're training them, not just educating them, what we would call this training them on like laws, what trends are around their neighborhood for them to be aware of, or you're trying to get something from them, like an agreement to, where are my environmental people here, but like an agreement not to, or to ID everybody that comes into their establishment, regardless of what age they look like, all these things, or placing advertisements higher than 5 feet so it's not at height with a young person that's 5, 6, or 7 years old. We don't need alcohol advertisements low for a 5-year-old to see, right? So we're talking about placement. And so if you make agreements and you're educating them about what we call product placement, we used to have the 3 Ps: placement, product placement, price, and advertising, right? So if if you're training them on those things, then it would fall under retailer compliance and recognition. Any other questions? It's nice we're spending this much time on environmental, because usually we're not. So I really like that. We're here. And for those of you that are like, what the heck is this? I would highly encourage you to build your capacity around environmental, because we don't do just direct services. We do so much more in prevention. Okay, I'm going to move on to the IOM categories. So remember, under problem ID and referral, it said like based on the level of need, right? To make a screening so that you can identify level of need. So in prevention, we have 3 levels of need. They're universal, selective, and indicated. I kind of just want to yeah, I'm going to just free flow on this. So universal is when we have anyone can attend. We don't have like a criteria of who attends. We don't know what risk level people are when they attend. So an example of this even is if we're doing Too Good for Drugs in a school. We just go in, we meet with the kids every week, but we don't know if they're using or not. We don't know their background. We have no idea. And so all of that classroom would be universal. Even though you might know 3 of them are using, you're not there for that. You're there just to give an educational curriculum to these 30 kids. Now let's say some teachers or the principal has say, okay, out of the kids, there's 5 or 10 kids that have been caught with a cigarette or maybe paraphernalia, or actually maybe they got caught with a joint. And so they want them to get like some type of not counsel, but a focus group, a mentor, or what we would call sometimes a brief intervention. Those kids would be under selective. So they've been selected as having a need for more service. And so they fall under selective. Now let's say I'm with these 5 young people, and Lorraine is just wiling out. Her grades are down. I know she's using. Maybe mom is, she tells me mom is using. So I might decide to just pull Lorraine and say, Lorraine needs some intense services. I want to do one-on-one. And now she'll become indicated. So the service that I'm providing her at that point will become indicated. I like to remind myself that IND is individual. So if I'm providing an individual service for a young person that has been shown or expressed or has been referred with a lot of need, indicated. And then selective, of course, is like when they're referred or selected in some kind of process. And again, when you go back to problem ID and referral, that screening could be that process. And then universal is when you don't know the level of need. You're just providing a service to everybody that attends. So here's the breakdown of universal prevention. Again, everyone in a population, and you're not selected for the base of your risk factors. You're just everyone's receiving. I don't think I'm letting any more people in at this point. Sorry. So universal direct is when service recipients are present and not receiving primary prevention services based on need. And then you'll have your universal indirect services, such as environmental or your information dissemination, some community-based process. It's when the whole population is going to receive this. So like a social host ordinance, it's the whole population, the whole zip code. You don't know the level of need of everybody in there, but this policy is going to impact everyone, but you're not working directly with them. You're creating policy or whatever, and that would be a universal indirect. Moving to selective, now here we're saying known to have specific risks for abuse and recruited because of the profile. So just like I was giving you the example before. And it could be too that you're providing curriculum. If you create criteria for your program, you might automatically be selected. So for example, I used to do gang intervention, but they also used to be identified as a gang member through police enforcement, and they had to be under poverty. So that already makes my program selective. And then indicated prevention is individuals experiencing early signs of use, but who have not been diagnosed as needing treatment. And it is at this level where if you're working with a young person that you say, oh, their behavior is not going to stop, and then you say, I'm going to refer them to a treatment assessment, then you can refer them to a treatment assessment. But treatment assessments cannot be paid for with primary prevention dollars, but the referral can. So you're referring them to go get some, and it could be a mental health assessment, but within prevention, we are not clinicians to provide those assessments. So if they say, I'm not going to go get assessed, or you can refer me, I'm not going to do it, then it's your choice to decide if you have the capacity to provide them indicated service, or maybe there's another program externally that you can refer them, that they might have a program that can better serve them at an indicated level. Questions on IOM? There's a lot here. You should read through it and get more familiar with it, but I think I definitely got to the point to differentiate between the three. Any questions?
There's nothing in the chat.
Beautiful. Okay, I am going to mute myself, get some water, and Angelina, take it away. You're on mute.
Thank you. I forgot. So thank you, Lorraine. And let's wrap up by looking at our last chapter, chapter 5 for demographics. Counties should be reporting exact demographics for programs where identifiable participants receive a service. These types of programs use the following IOM categories Lorraine just went over with us: universal direct, selective, and indicated. Programs classified with these IOM categories would include the following primary prevention strategies: alternatives, education, and problem ID and referral. Programs classified with the environmental primary prevention strategy shall enter demographics when a policy is formally enacted. The strategies of community-based process and information dissemination fall under the IOM universal indirect and do not receive demographics. Within our ECHO data collection system, these types of services would be entered under your community-based process grouping. My favorite part of the document, not including chapter 3, which I really like because of all the definitions, is this primary prevention services classification and demographics matrix. I love this chart. It provides a quick snapshot of how the strategy, activity types, demographics reported in IOM pieces all fit together. So we'll kind of scan through that. Now, are there any questions regarding any of this information for Chapter 5? Okay, so before we move on to any final questions that you might have at the end of our time together, I'd like to remind our attendees about important updates to our ecosystem for the new fiscal year for 24-25. So you did receive a notification at the county level earlier this week from your DHCS analyst, and I do just want to repeat this information again because it is really, really important. For providers who do not enter data into ECHO, this is just an FYI for you, but for our county and providers who work within the ecosystem, SAMHSA has revised its reporting criteria for the annual prevention reporting, which will take effect in the upcoming 24-25 fiscal year. To align with these new requirements, the ECHO tool will be updated to ensure that it supports this new data reporting format requested by SAMHSA. These new data elements include new age categories and new gender categories, and the specifics of those and what the changes look like were emailed to counties earlier this week. If you did not receive that or you need more information, please reach out to your DHCS analyst, and we'll be happy to provide that for you. There are several key dates and required actions to take note of. So first of all of your reporting, not just June, but all of your fiscal 23-24 reporting must be completed by July 10th of 2024. So July 10th, next month, everything that you plan to put for your 23-24 fiscal year must be in the system. This is crucial to ensure a smooth transition to the updated reporting format. From July 11th to July 15th, the Prospectus Group, who is our vendor who manages ECHO for us, will be implementing and testing the necessary updates to ECHO to reflect the new SAMHSA criteria. So during that period from July 11th to July 15th, ECHO will be unavailable for data entry or program creation. Beginning July 16th, which is a Tuesday, counties will be able to access ECHO to create programs for the next fiscal year. And throughout the fiscal year, please only create programs that will have a start date within 60 days. So in July, if you are creating a program, that means it will start in July or August. If it's going to start in September, we're requesting that you please wait. If it's going to start in May, then please wait even longer. So that would be in roughly April that you would create that new program. Okay. Any questions about any of that before I wrap up this part?
Can you just repeat
It's-
when 2023, 2024 is due?
Yes, once again, all of your 23-24 data by July 10th. The system will be, and Lorraine has also placed it in the chat. The system will be unavailable from July 11th to July 15th. And starting on July 16th, you may begin creating programs. And again, we request that you only start by creating programs that will be in process in July and August. So within that 60-day window. So we really appreciate your cooperation and flexibility during this. Oh, yes, Lorraine?
Yeah, I want to take a few minutes to go over this chart again, just because it
Okay.
was like so quick. Because I want you guys to look at this chart and know exactly what it means because it is so helpful. So you'll see like here's all the strategies on the left-hand side and then all the activities that go under each strategy. And then demographics, we're telling you, if you're doing alternatives, community service, we want the exact count of demographics into the system. And that can fall under universal direct, selective, or indicated. That's when we're monitoring, we're making sure that there's counts, demographics in the system. So you'll see under CBP, under all of these, that there's no demographics required and that it should always be universal direct. So I want you guys to make sure, remember, if you are putting in demographics into the system, you're always adding the new participants into the system but this will tell you what is exactly what we're going to be looking for. So education, we want exact counts, meaning cumulative. So if in January you met a group of 10 and you put 10 in January and then in February there were 12, so 2 new people, then in February you would put in those 2 new counts. So it's for the whole year, that's what the exact count is. So ID, no demographics. Problem ID and referral, you'll see here, this is the one time where we're saying universal direct is only could be for EAP prevention screening, but brief intervention and SABP will never have a universal direct. They'll always be selective or indicated based on that service. So I just want you guys to really understand how to use this chart, because you could just keep this chart by your desk and know exactly what to do if you don't need the definitions. That's all. Thank you.
Okay, and we do have
Thank you, Lou.
hand raised. Yeah.
Yeah. And there's a question in the chat, so we'll get to that second.
Yeah,
Whose hand
it
is
is being recorded. Rhea Alvarez, I am recording this.
And then Carrie, you had your hand raised. Did you have a question? You can unmute yourself and ask.
No, can you hear me okay?
Mhm.
Hello, Angelina. I haven't seen you in a long time.
Yes, not for a
I'm
while.
hiding today. It's Friday.
Okay.
I just found what I was looking for. I didn't realize that it was the new version of the data quality standards that was attached to the appointment with the link,
Okay.
but I have it now because I was going to ask where can I get the grid, but I figured it out. So thank you. Have a good
Okay,
weekend.
cool.
I am going to make a couple of corrections on this document, and so we're going to send this document out.
A new one, you mean?
Yeah, but it's just an acronym I missed, so I will send this out to all the county coordinators to give to all the providers one more time.
Yeah,
I do
and
have
we'll
one weird thing to say, by the way. Sorry, go ahead.
No, I was going to say, and we'll also swap out the version in Echo, in the Echo briefcase. So counties and providers who work within Echo will have access to that as well.
Oh, perfect.
Yeah.
So with respect to that one section under community-based process that used to be systematic planning, that was the one category that I noticed had shifted to primary PV strategic plan development. So should we just consider it kind of like the same thing? Just the title has changed? So that's kind of what I got from what you were saying and what we were assuming.
It is the same thing. We just had some providers not understanding the difference between
Plan and then including it under planning.
Yes.
Okay,
Yes,
that's what I
so
was thinking.
we changed the title.
Right. Okay. Thanks.
Nice observation, Carrie.
Yep.
Beautiful.
Okay. Any other questions about anything? All right. Well, if you think of something after we finish today. Oh, wait, we have a hand up.
Just curious, would there be training on how to duplicate the badges in the new program?
There is a video under the training videos, as well as you can still request through the help desk within Echo training from the vendor. And then, of course, your DHCS analyst, I know for myself, speaking for myself, I'll be going over that with my counties and walking them through that process. It's really easy. So like,
Sounds
really,
good.
really easy. It's one of the reasons we love this system is the ease and the of use. It's very, very user friendly. So good question. Any other
Just
questions?
one more, I'm sorry.
Oh, no.
There's one program that you're mentioning that you only make a program when you know you're ready to start. In this 23-24 year, there was only one program that it was going to start and then it got scratched. It's still in there. Do I
Then you'll
just
work, yeah, work with your DHCS analyst to get that deleted. And that
Okay.
is something that all of us are going to be discussing with our counties, is to delete any programs that did not end up getting used and have absolutely no data underneath them. And so each of us will be working with our individual counties to address anywhere where that's where that comes up.
Okay, thank you.
Okay. Guys are asking great questions. Any more? Okay. Well, if you think about something after we wrap up today, please reach out to your DHCS analyst or to the help desk. We're always happy to help. We're here for you guys to support you in any way we can. And I'd like to thank you all for attending. You have some great questions, and hopefully this has been a helpful information to share with you. Okay. Thank you.
Thank you, Angelina. Bye-bye.
Lorraine, you stopped recording? You can stop recording. Put that together mode is interesting.